Good afternoon, everyone. Welcome to our PeaceHealth webinar on colon cancer, what to watch for, and how to prevent it. The information presented today is general in nature and doesn't replace advice for your personal healthcare provider. In fact, we do encourage you to talk with your doctor about specific questions related to your diet and health conditions. My name is Summer Meyer, and I'll be your moderator today. Before I introduce our two guest speakers, I would like to remind you that PeaceHealth is safe, open, and ready to help when you need us. And it's now easier than ever because we do offer video visit appointments. So if you haven't done so already, sign up for My PeaceHealth. There you can make appointments, track vaccinations, and receive test results, even manage your prescriptions. If you have an account already, just make sure you log in and update your contact information. In today's webinar, I do want to invite you also to engage with us by voting in our polls, asking questions in the chat, and even taking our survey at the very end. So now with that housekeeping out of the way, it's my great pleasure to introduce to you our speakers. First, please welcome Dr. Kabrawala. Dr. Kabrawala practices gastroenterology and internal medicine at our specialty clinic in Longview, Washington. He is very passionate about the role of diet and lifestyle modification in managing gastrointestinal issues in a path to healing our gut. Dr. Kabrawala attended St. George's University School of Medicine in Grenada and went on to do his internal medicine residency at Stony Brook University Hospital in Long Island before completing his gastroenterology fellowship at Sunny Health Sciences Center in Brooklyn, New York. He's worked for us at PeaceHealth for almost 4 years now. When he's not at work, you can find Dr. Kabrawala spending time with his beautiful wife and 2 adorable children. And he also loves to bike, garden, and create culinary experiments at home. So thank you so much for being here with us today, Dr. Kabrawala. I will also introduce to the audience now our second speaker, Dr. Dhami. So welcome, Dr. Dhami, as well. Dr. Dhami practices radiation oncology at our PeaceHealth Southwest Medical Center in Vancouver, Washington. And she's very passionate about connecting with her patients and their families to maximize their quality of life, both during and after receiving care. Dr. Dhami attended the University of Texas Medical Branch for her medical education and her internship. And then she came to the Great Pacific Northwest to attend the University of Washington Medical Center for her residency in radiation oncology. She's currently completing her Healthcare Master's of Business Administration at Oregon Health and Science University. And she finds science, including the physics and biology behind radiation therapy, fascinating. But when she's not at work, you can find Dr. Dhami spending time pursuing a healthy vegetarian lifestyle and exploring the outdoors with her husband and 2 daughters, and even their dog named Pavlov. So thank you both for being here with us today. And I would like to now hand it over to Dr. Kabrawala first to give us a brief overview of what to expect in today's webinar.
Thank you, Summer. It's a pleasure to be here, and I'm truly honored to be speaking amongst our community about colorectal cancer screening and helping everyone improve their gastrointestinal health. I want to give a special thanks to my wife, Swetha, who helped me prepare for this wonderful discussion we're about to have. Today, I'd like to cover sections to help you understand more about colon cancer, what to watch for, but most importantly, how to prevent it. Let's start by taking a look at the colon itself. The colon is also known as the large intestine, and it comprises the entire colon named in different sections. It includes the cecum, which is the beginning of the large intestine, and the rectum, which is the very end. It's about 5 feet long, which is about 20% of the entire length of the gastrointestinal tract. And it is now well known that it is packed with over 1,000 different species. And millions of these bacteria, both good and bad, live in our colon. Many of these, however, provide real health benefits to the body. Colorectal cancer is the third leading cause of cancer in both men and women in the United States. And the lifetime risk of developing colorectal cancer is about 1 in 20, even without a family history. And it's also the third leading cause of cancer-related deaths in both men and women. This year alone, nearly 135,000 people will be diagnosed with colorectal cancer. And unfortunately, about a third of those people are expected to die from it. As you can see, colon cancer is a major health problem. But guess what? In the United States, incidence rates have actually decreased by about 2 to 3% per year over the last 15 years. And the death rate has also been dropping. And do you know why? It's because we've been screening for colon cancer. When we screen, we literally look for polyps and remove them before they turn into cancer. As many of you know, when you turn 50, you should get screened for colon cancer. But this year, new national guidelines have emerged that have changed those recommendations to age 45. This is because we recognize that precancerous polyps develop earlier than age 50. So if you're 45 years or older, talk to your doctor about getting screened now. And as I said, everyone should start screening at age 45, but there are 3 major risk factors in which you should start screening even earlier. Those include, number 1, if you have a first-degree relative with colon cancer. Number 2, if you have inflammatory bowel disease. And number 3, if you are African American.
Thank you, Dr. Kabrawala. So at this point in time, I would love to launch a poll and get some interaction from our audience. Which risk factors for colon cancer concern you the most? Is it the age, gender, maybe family history? So I'll just give you some time here to type in the chat. Looks like about 20% of our attendees have voted so far. If it's something else that's not listed here, feel free to type a message for us in the chat and we can make sure that you're included. Let's see. Okay, I'll just give you a couple more seconds here. And okay, so I am going to close it up. So get those responses in and I'll close the poll. Looks like we've got a pretty clear winner here. Let me go ahead and share out these results. So I don't see the screen on my end, but it looks like age for the attendees of the webinar today is the most concerning at 56%, and then family history takes second at 29%. So we'll keep that in mind as we move along, and I'll hand it back over to Dr. Kabrawala to dive a little deeper into our risk factors. And so let me hide the poll and make sure that you all can see my next slide.
Well, that's very appropriate that people feel that age is a big risk factor. Well, let's talk more about it though. Let me direct you to the graph we have here. As you can see, there is a dramatic increase in the number of colon cancer cases as you get older. However, and a very important second point that I'd like to emphasize is that even though there are many more cases beyond age 60, about 12% of colorectal cancer cases this year will be in people under age 50. That's about 20,000 new cases per year. Let's take a closer look at family history now and hereditary conditions. Family history is another irreversible risk factor and one that you should not take lightly. If you have a first-degree relative, such as mom, dad, sister, or brother, who was diagnosed with colon cancer, you should start screening even earlier. We recommend 10 years younger than the first-degree relative that was diagnosed, or 40 years of age, whichever one comes first. For example, if your mother was diagnosed with colon cancer at the age of 52, we recommend that you start screening at age 40. But besides getting screened at an earlier age, these people need to be screened even more often. In these situations, we recommend repeat colonoscopy every 5 years. Also, there are some families that have a very strong genetic makeup for getting colorectal cancer, like familial adenomatous polyposis or Lynch syndrome. There are families, fortunately not many, however, where the genetic makeup is such that everyone will get colorectal cancer if preventative steps are not taken. Furthermore, if you've been diagnosed with inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, specifically when it involves the colon, you too qualify for earlier screening. And lastly, African Americans are at a much higher risk than non-African Americans. Last year, we mourned the untimely passing of actor Chadwick Boseman at the age of 43 from colorectal cancer. Unfortunately, his story is not unique, as Black men and women have the highest rates of colorectal cancer incidence and mortality compared to all other racial and ethnic groups. Mortality is about 20% higher in African Americans compared to Caucasians. Even before our new national guidelines this year, most healthcare organizations were already recommending that African Americans start screening strictly at age 45. Let's now switch gears a little bit. Let's talk about how your lifestyle and diet can influence your risk of colorectal cancer. There is plenty of evidence that shows that there are both good and bad influences that play an important role in the occurrence and the progression of this disease. Bad influences such as obesity, alcohol, consumption of red meat, eggs, processed meats, cigarette smoking, physical inactivity, refined grains such as all-purpose flour or white bread, and sugary foods, of course, like our donuts or candy, soda pop. We'll talk a little bit more about the good influences on the next slide. There is very convincing evidence that heavy alcohol intake, which is defined as more than 4 drinks per day, is a significant risk factor for hurting our gut flora, which in turn increases our risk for colorectal cancer. Many people, however, they don't drink this much. So how about 1 to 3 alcoholic beverages per day, including beer and wine? Well, a new study this year, which is a very good type of study called a meta-analysis, shows highly suggestive data that this too increases our risk for colorectal cancer. Secondly, eating a significant amount of red meat causes changes within our gut bacteria that leads to changes at the cellular level of your own body. This in turn promotes the risk of colorectal cancer. It has been shown that there are cancer-causing substances that are generated in the gut in the presence of red meat, such as beef, pork, veal, and lamb. This is because red meat, processed meats, and even eggs are high in what's called heme iron. Heme iron is iron that is found in the hemoglobin of animals, which leads to the damage of our own DNA and promotes the synthesis of substances that damage the gut and lead to cancer. So, how much red meat is too much? Well, one study showed that eating an average of 75 grams of red meat per day is associated with a 20% higher risk of developing colorectal cancer compared to consuming only about 20 grams a day. Just so you'll know as a reference, 75 grams of red meat is about a roughly 3-ounce steak. Now, let's talk about the good influences in our gut, like a plant-based diet or a semi-vegetarian diet. As I introduced earlier, we have over 1,000 different types of bacteria, and this amounts to trillions of bacteria in our gut. But the best and the most desirable bacteria rely on plant food fibers for their own health. When these healthy bacteria predominate within the colon, certain cancer-causing materials called carcinogens are less likely to be present. This seems to be the reason that eating a predominance of plant foods is a great preventable measure. In fact, the single greatest predictor of a healthy gut flora is eating a variety of fruits, vegetables, and legumes, which includes beans, lentils, and peas. We know that inflammation in our gut is a very important role in cancer development, including colorectal cancer. So we want to minimize the pro-inflammatory foods such as red and processed meats and simultaneously increase anti-inflammatory foods in our diet, such as whole grains, legumes. These are known as prebiotics. We also want to increase our consumption of calcium and vitamin D, which has been shown to bind the bad bile and the bad fatty acids that come from our liver, and that helps minimize their toxic effects in the intestines. Finally, a diet high in micronutrients like magnesium, folic acid, all which comes from our vegetables, significantly reduce the risk of colorectal cancer. Another very important good influence to your diet is fiber. 95% of Americans don't eat enough fiber. It's recommended to eat about 25 to 30 grams of fiber per day. If you want to increase your fiber in your diet, some tasty foods can include avocados, broccoli, chia seeds, chickpeas, raspberries, green peas, just to name a few. These contain a lot of fiber. Many people, however, may argue that if dietary fiber is not absorbed in our intestines and is left undigested, then why is it even important? Well, the answer to that question is a much longer discussion that we're going to have here today, but to shed some light on the topic, we know that fiber within the plant foods feed the very best bacteria within our gut. And these bacteria, in turn, keep the lining of our colon much more healthy and less likely to change into colon cancer. So I mentioned in the last couple of slides about prebiotic foods, such as fiber, that feed the good gut bacteria and allow them to flourish and thrive. Now let's talk more about probiotics. Probiotics are actual live bacteria that are consumed. Yogurt, sauerkraut, kimchi, and other probiotic-containing foods increase the presence of lactobacilli and other good bacteria in your gut so that they can do their job in breaking down toxins and restore your damaged gut flora, which may have been injured over our lifetime, including from alcohol, tobacco smoking, poor diet, and even antibiotics. Now, who likes coffee? I know I do. How about dark chocolate? Guess what? Well, these are great for your gut flora. These are types of polyphenols. Polyphenols are plant-based antioxidants that reduce inflammation in our colon. Other examples can include green tea, olive oil, nuts, berries, flaxseed, turmeric. Several studies have shown that they help prevent the development of colon polyps and subsequently colon cancer. Now, we've talked about risk factors, diet, and lifestyle that can definitely change or increase your risk for colon cancer. Well, what if you have colon polyps or even colon cancer? Would you have symptoms? Well, the unbelievable part is about with people who have colon polyps or even colon cancer is that you may not have symptoms. Many people have no symptoms. However, if symptoms do develop, you can have bright red blood per rectum, ongoing iron deficiency anemia in any male or a postmenopausal female, or new changes in your bowel habits like new onset constipation. However, since most people have no symptoms at all, let's talk more importantly about the different types of colon cancer screening that is recommended to everyone. There are several ways to get screened for colorectal cancer. Let's talk about stool-based tests first. I get questions about this one all the time. Stool tests detect small amounts of blood and or genetic material from our colon, and there are three types. There's FIT, Guaiac, and Cologuard. The most common of these tests is FIT, so your PCP may recommend doing this test. The newest of these tests is called a Cologuard. Cologuard is about 90% sensitive in detecting colon polyps and or colon cancer, compared to 70% in FIT and only 35% in Guaiac. So, if you test positive for any of these tests, you need to have a colonoscopy in order to find and remove precancerous polyps. I would, however, still recommend that everyone get at least one colonoscopy, regardless of the results of their stool tests. Why? Because colonoscopies are 95 to 99% sensitive in detecting colon polyps and colon cancer. Unlike breast, lung, and many other forms of cancer, colon cancer is remarkably preventable if colon polyps are discovered and removed before they come into cancer. Now, a colonoscopy can help reduce colorectal cancer incidence by about 40% and mortality by half. It is a very safe outpatient procedure with basically no recovery time. I find colon polyps very frequently on first-time screening colonoscopies, even after a negative stool test. My job is to remove them because colon polyps turn into colon cancer. This is why I urge the importance of colon cancer screening. Colonoscopies literally prevent colon cancer. There is no other screening exam that can prevent the cancer from developing. This is truly an amazing, unique opportunity. So, as I mentioned earlier, the guidelines for colon cancer screening are in the process of changing this year. And most medical societies have recommended for years to start screening at age 45 so that we can detect precancerous polyps and remove them if necessary. Starting this year, new national guidelines recommend to start screening at age 45 on normal risk adults, meaning those without a family history.
Very good. Thank you again, Dr. Kabrawala. This has been incredibly informative. At this point in the webinar, I would like to launch our second poll to get some audience participation. This time we are asking, given all that you've just heard from the first portion of our presentation, Have you or are you planning to be screened for colon cancer? So I'm going to get this launched, and let us know if maybe you've already been screened, maybe you're thinking about making an appointment, talking to your doctor, especially given what you've just learned this afternoon. Or maybe you're not quite ready just yet for a screening. It could be that you don't have certain risk factors, or maybe you're not 45, or maybe it's something else entirely. So feel free to let us know that as well. All right, looks like we've got over half of our participation already. The votes are in. A couple of things I did want to mention. I always learn something amazing during these webinars, which is why I love to moderate. But I really appreciated you mentioning about the prebiotics and the probiotics. And I had no idea that vitamin D and calcium were used to bind sort of the bad things. But also kudos to mentioning coffee and dark chocolate. So I know that those two things are great for my own gut flora, which I'm going to continue consuming. So at this point, I'm going to go ahead and close up the poll, and let's take a peek at the results. It looks like 75% of our attendees today have already been screened. So great job. And 18% are thinking about making appointments. So that is just fantastic. Let's move on into transitioning to the second portion of our presentation today, where we're going to welcome Dr. Dhami, and she's going to talk to us about the differences between the colon and rectal cancer, as well as what happens after a screening when cancer is detected. Dr. Dhami, I'll hand it over to you.
Thank you. Thank you, Dr. Kabrawala, for the thorough review on prevention and screening for colorectal cancer. At this time, I would like to transition the discussion to what happens in the event a cancer is detected during the workup. Before we proceed with the discussion on treatment, I would like to dive into some of the nomenclature. The terms colon cancer and colorectal cancer are often used interchangeably. However, there are important differences between colon and rectal cancers, which impacts the treatment management. The rectum is approximately the last 12 centimeters, or about 5 inches, of the large intestine. It takes specialized imaging and experts to differentiate the rectum from the remainder of the colon. Why is this important? The primary reason is that the rectum does not have the same protective outer layer, called the serosa, as illustrated on the slide, as the colon. As such, it is easier for rectal tumors to break into the wall and spread locally. Because of this risk, as well as the rectum's distal location, rectal cancers involving nearby lymph nodes or have growth through the bowel wall into the surrounding tissue often require additional treatment, such as chemotherapy and radiation therapy, to shrink the tumor before going to surgery. If cancer is discovered, staging of the cancer entails additional workup, which can include additional studies such as a CT scan and labs. Prognosis of colon cancer is based on the spread of it. If colon cancer is contained within the colon, prognosis is excellent after surgical resection. If, however, lymph nodes are involved, chemotherapy in addition to surgery may be required and prognosis will vary. There are 4 stages of cancer. Stage 1 colon cancer is localized within the colon muscular wall. Stage 2 colon cancer is when the cancer invades through the wall into the surrounding tissue or organs. Stage 3 colon cancer is when the nearby lymph nodes are involved. And stage 4 colon cancer is when the cancer spreads distantly to other organs. For colon cancer, the mainstay of treatment for localized disease is surgery. The final stage of the cancer is determined after surgery. A pathologist will review the tissue removed at the time of surgery, including the lymph nodes, to accurately stage the tumor. This information helps a multidisciplinary care team on providing individualized input on what additional treatment may be recommended. After surgery, a patient may be referred to other physicians, such as a medical oncologist, who would discuss the role of chemotherapy to reduce the risk of cancer coming back, such as for larger tumors or tumors spreading to the lymph nodes. This slide highlights the importance of catching colon cancer early, as the survival outcomes are significantly improved with stage 1 cancer as opposed to stage 4 cancer. Now, I would like to hand the presentation back to Dr. Kabrawala for the key takeaway points when it comes to prevention.
Thank you, Dr. Dhami. So, how do we prevent colon cancer? Well, as I mentioned, you want to limit your alcohol intake, stop smoking tobacco, limit your red meat, eggs, and processed meats, eat tons more fruits, vegetables, fiber, so that you can feed your good gut bacteria. And of course, enjoy a daily coffee pick-me-up and some dark chocolate. But most importantly, get screened starting at age 45. Thank you so much for having me here today.
Wonderful. Thank you so much to both of our providers, Dr. Dhami and Dr. Kabrawala. At this point in the presentation, I would like you to start kind of thinking about what questions you have. We've left ample time today for you to actually go ahead and type in our Q&A, and I would be happy to pose some of these questions to our physicians on the line. While you're thinking about that and getting those questions ready, I do want to remind our entire audience that we will have this recording posted to our website as well as slides. And we do have a couple of handouts that will be linked as well. I believe they're uploaded here where you can actually download them from this platform. There's a booster fiber intake that talks about all the great foods and their fiber so that you can make sure you're getting enough of that, as well as a colon health overview handout. So let's see, let's go ahead and dive into the questions. I want to make sure that I am able to see those here. And then if our doctors want to come back on the webcams, feel free to turn your webcams back on. So there is a question here, looks like from Sherry. Question about taking supplemental probiotics. Any thoughts about that or any feedback on what about supplemental probiotics?
Yeah, thank you so much, Jerry. Supplemental probiotics, I first advise people that when you're taking a probiotic, you want to make sure it includes lactobacilli. Lactobacilli has been shown to really restore our gut flora through lots of different evidence. Another very important bacteria that we take or probiotic that we can take is bifidobacteria. That's spelled B-I-F-I-D. But really the driving home point for probiotics is that you want to try to get it through dietary food, so through your diet, either through sauerkraut or yogurt or kimchi, as opposed to a supplement. Because the bacteria that's in our food or that's in our, the probiotics and the bacteria that's in our food is a lot more abundant, a lot more natural, and can definitely help restore your gut flora.
Very good, thank you. We do have another question from Alicia. I hope I'm saying your name correctly. How often should you be screened after adenoma or polyps are removed in a colonoscopy? It's a great question.
Yeah, great question. It depends on the size of the polyp, so and what type of polyp it is. So if you have what's called an adenoma or villus adenoma, also known as a tubular adenoma, generally speaking, you want to repeat your colonoscopy in about 5 to 7 years. If the polyp, however, is large, meaning greater than a centimeter, or it contains villus tissue, and your doctor would let you know about that, you want to do this in about 3 to 5 years. You want to repeat in about 3 to 5 years.
Excellent. This is great feedback. Thanks, Joseph. Looks like he's just given some kudos here, saying it's a great presentation. He appreciates this proactive educational approach and would like us to offer some more of these. So this is great, Joseph. I appreciate your feedback there. And then there's another question. So it looks like David's interested in finding out where he can get a Cologuard exam. That was the one that was like kind of the most, if I recall your presentation right, sort of the most kind of accurate as far as the highest percentage in being able to actually detect and find any issues.
Yeah, just like all screening, colon cancer screening, it starts at the primary care doctor's office. So when you talk about colon cancer screening, talk about the different options with your primary care doctor. That can include FIT testing, Cologuard, of course, a colonoscopy. Now, I understand that many insurance companies so far are still not approving for Cologuard, so they do a lot of what's called FIT testing or fecal immunochemical testing, which is of course less sensitive, but you have to check with your PCP and your health insurance provider whether Cologuard is approved. And of course, if it's not approved, then there's always the option of paying out of pocket, but that can be very, very expensive.
Thank you. These questions are all great. Thanks to our audience members. We've still got some more coming in, so I'm just going to kind of keep ticking down this list here. The next one from Jill: are hemorrhoids related to colorectal cancer? That's a good one too.
Do you want to take this, Dr. Dhami, or?
Sure.
Yeah.
So no, so hemorrhoids are just dilated vessels. Often can be related to maybe constipation and having to bear down. Certainly hemorrhoids, if patients are undergoing radiation therapy, can be inflamed and cause more discomfort during radiation therapy, and that's not uncommon, but it's not related to colon cancer. And Dr. Kabrawala, do you have anything else to add?
I completely agree. Hemorrhoids are usually due to a paucity of fiber in our diet. So the first treatment when you have hemorrhoids is increasing your fiber either through dietary fiber or through a supplement like psyllium husk.
Great, thank you. And our next question here, this is an interesting one, because I know that you mentioned cigarettes specifically on the presentation. So this question from Chris is nicotine a contributor? So nicotine gum, maybe more specifically, but is it the nicotine that's a contributor to the colon cancer? With the understanding that looks like Chris understands tobacco is, but what would your thoughts be about that?
To my understanding, it's really cigarette smoking, not even so much nicotine, and unfortunately not so much even the chewing tobacco. Chewing tobacco does increase your risk for other cancers like oral and throat cancer, but we're seeing specifically that cigarette smoking increases your risk for colorectal cancer, colon polyps, and also, just to add one point, cigarette smoking increases your risk for colon muscle wall weakening. So the bacteria tend to change in our colon, and a lot of this does come down to the bacteria. So you're actually kind of injuring the bacteria when you do cigarette smoking, which in turn increases your risk for colon muscle wall weakness and colon cancer. I hope that answered your question.
One thing I also would like to add to that is we know that smoking causes inflammation. And so patients who are, have a diagnosis of cancer and are actively smoking, it can actually delay healing and recovery from treatment. So there's, and also increase the risk of cancers down the line. And if there are questions about smoking cessation, please discuss it with your primary care physicians or your care team. There's a lot of resources available for you.
Excellent, thank you. Here's a great one. I would like to know this too. This one came from Jill. Do we need to have probiotics such as yogurt, on a daily basis, or is it fine to have that just like a few times a week? Like, what's, your recommendation as far as frequency goes? And feel free to even expand on that, because I'm kind of curious about the pro and the prebiotics myself.
Yeah. So prebiotics is fiber, essentially fiber. And what that does is it feeds your good gut bacteria. So you want to feed your gut bacteria every single day. Probiotics are actual live bacteria that are consumed as a supplement or through diet, either yogurt, sauerkraut, etc., that adds to the bacteria that you already have. We already have lactobacilli in our colon, or bifidobacteria in our colon. So probiotics is taken as a supplement to add to that. Now, there's lots of reasons to take probiotics. There could be, maybe you've damaged your gut bacteria. Maybe you've been diagnosed with a bacterial overgrowth problem. And there's several reasons to take probiotics. Now, as far as everyday use versus several days a week versus several days a month, that's very hard to quantify. There's very few studies that show one way or another is better. I would say that it's best to try to take it several times a week, though. And the dietary probiotics, much better, or better to do every day or every several days a week than just taking a supplement, either through yogurt, because either through yogurt or sauerkraut or etc. Now, yogurt also has calcium and vitamin D. And we know that taking calcium and vitamin D, specifically 1,000 to 2,000 international units of vitamin D daily, reduces our risk for cancer in general, including colorectal cancer. And the reason we think that is because it literally binds the bad bile and bad fatty acids, which are degradation products from our liver, and that in turn reduces their toxic effects in our intestines. So there's kind of a dual benefit to taking yogurt every day.
Not to mention that vitamin D is great, right? We all kind of need a little bit more of that here in the Pacific Northwest. That's actually a really great reminder for me, because I was taking it and now I sort of fell off the wagon. So I need to re-up my vitamin D.
I'm guilty as well. I'm guilty as well. So yeah.
This is great. I feel like I'm getting a free health consultation from 2 doctors at once. This is amazing. I hope our audience members are enjoying it. It looks like they are. There's a couple more questions that I would like to share. This is a really interesting one from John. The prep for colonoscopy is probably the most unpleasant aspect. Are there any improvements? Can you talk a little bit about that? I actually don't know anything about the prep portion.
So we've been running to this problem forever, of course. People are fearful of completely evacuating their colons, and can rightfully so. You'll be in the bathroom all night. You spend all morning, all night going to the bathroom, and then you have to go to a colonoscopy procedure. So it can be very uncomfortable. Previously, we used what's called Go Lightly, which is a 4-liter jug, and it does a very effective job in getting out the stool from our colon. More recently, we're using what's called Suprep, which is 2 16-ounce bottles, so significantly less than what we were using previously. Another thing that we're doing more recently over the last 5 years is that we're splitting it up. So we use half the prep the night before and half the prep the morning of the procedure. All should be completed about 4 hours prior to the procedure time. And the reason we're splitting it up is not just because of the patient's satisfaction and making sure that you can actually tolerate all of it, but actually noticing that the closer you are to the colonoscopy in terms of preparation, the cleaner one will be. Now, we're also coming out with tablets. Over the next 5 years, we'll see a lot more preparation from tablets. There's one company that makes SuTab, which is 24 tablets, 12 tablets taken the night before and 12 tablets taken the morning of the procedure. Now, with that said, you're still going to have to drink a lot of fluid, and it's going to be about 40 ounces of water with those tablets. So regardless of what you do for preparation, a lot of liquid is required to evacuate the colon. Otherwise, you're not going to get a good bowel movement. You really can't have a good bowel movement without enough hydration. And in order to really get out and evacuate your stool, you need to have a lot of adequate hydration. But I would recommend talking to either the gastroenterologist or your PCP about different methods of preparation and which ones may be more tolerable than others.
Very good. Thank you. This one's from Lawrence, this next question. This is a good one too. Is there an age, because I know we heard the age 45 was more recently in the scientific evidence of when we should consider having a colonoscopy, but is there an age when colonoscopies are actually no longer desirable after a series of precancerous polyps are removed in every, looks like 5-year colonoscopies? So I think the gist of that is really like, is there an end date to our colonoscopy screenings or preferences, or kind of, can you talk a little bit maybe about that to help our audience members understand? Oh, and I think you might be on mute, Dr. Kabrawala.
This is a question that I get all the time. Someone coming in at the age of 75 saying, is enough, you know? And what I like to say is, if you are healthy, that's number one, you know, that you're walking on 2 feet, you don't have too many medical problems, that you can tolerate anesthesia or tolerate a short procedure, then, and you have a really strong family history, or you've had lots of polyps in your lifetime, then it's best to continue generally up until the age of 80. Now, with that said, we say if you are average risk, meaning that you don't have a family history, or you've only had maybe 1 to 2 polyps in the 3 or 4 colonoscopies you've had in your lifetime, we typically recommend stopping at age 75. But there are, you know, lots of different factors that are involved. So really what it comes down to is your overall health. If you're healthy and you've had lots and lots of polyps, it's best to continue usually up until 80.
Very good. Okay, looks like there are a couple more questions. I love this one. How much coffee daily is good? I know I might throw in chocolate to that too, since you mentioned dark chocolate, but is it okay that I drink a couple cups of coffee every day?
Yes, and so black coffee specifically, I try to emphasize that these are called polyphenols. Polyphenols are antioxidants. I'm sure you've heard a lot about antioxidants. We see them in berries, flax seeds, dark chocolate, black coffee. Typically, we say about 1 to 2 cups of black coffee every day should be okay. Several times a week, that literally reduces our risk for developing colon polyps. And to add to that, being a hepatologist myself, it also reduces the risk of fatty liver disease, 1 to 2 cups of black coffee every day. And that's, of course, without the additive sugar and creamers and all the other stuff that, or, you know, going to Starbucks and getting our frappuccinos. I'm talking about specifically black coffee.
Okay, very good. That's what's in here. So I've got my black coffee. Think I'm all set. This one's an interesting one, and I'm not sure if you know about this. This might be a scheduling question, so feel free. If we don't know, we can get you an answer later. But is a PCP referral a must, or can I just choose a provider and call them up and directly schedule my appointment if I wanted to get screened?
PCP referral is a must for colonoscopy, for colon cancer screening. However, you do not need to see the gastroenterologist in his or her office before you do the colonoscopy. It's usually what we call a direct access referral for colon cancer screening.
Okay, very good. And let's see, I don't actually know what C. diff is, but we do have a question from Catherine. Does a history of C. diff increase the risk of colon cancer? Do we know that?
So the answer is no, it doesn't generally increase the risk of colon cancer. But with that said, though, Clostridium difficile colitis, which is unfortunately, for people who don't know, it's a very bad bacteria of the colon that actually, believe it or not, is also a natural inhabitant of our colon. But when surfaced at the colon level due to an overuse of antibiotics, can really cause terrible, terrible symptoms. Diarrhea, electrolyte abnormalities, can make someone very sick, unfortunately. But it doesn't increase the risk for colon cancer. But with that said, you know, when you have Clostridium difficile colitis, you want to make sure that after treatment, you are doing whatever you can to restore your gut flora. Kind of the stuff that we talked about, taking prebiotics like fiber, taking probiotics like yogurt, taking calcium and vitamin D to, you know, minimize toxic effects to our intestines.
Very good. So I do want to move us along here. Thank you so much for an excellent Q&A. If your questions weren't answered directly, specifically, or if you think of other things as you go on, you can always email us at healthyu@peacehealth.org, and we'll try to make sure that you get your questions answered. And I also want to make sure you know about our monthly e-newsletter. We do fill it with health news, local events, and alerts about our upcoming webinars. So make sure that you join our mailing list if you haven't already at peacehealth.org/healthyu/subscribe, and you'll get invitations for upcoming sessions. Finally, I do want to let you know we value your feedback. You'll get a short 3-question survey after this webinar is finished. We do read each and every comment so we can make sure to improve for the next time. And I do look forward to hearing what other topics you might be interested in seeing. And then just a final thank you to Drs. Kabrawala and Drs. Dhami. Thank you so much for spending your lunch hour with us. I'm sure you've got patients to see right after this. And we really do appreciate your expertise on colon health. So until next time, please everyone stay healthy and be well.
You're welcome. Thank you for having me.
Thank you for having me as well.
Bye-bye.
Bye, everyone.